that you have on the slide, you see on top there, you have a man that have hamstring muscle tightness. He's having hamstring muscle tightness, and the therapist maybe is doing PNF stretching or something like that. You know, when a patient have hamstring tightness, to do extension will come with pain because the hamstring will stop the quadriceps from extending the knee. So it's painful. Extension is a movement of pain for patients that have tight hamstring. We call it movement barrier. It's a direction of movement barrier in manual therapy. But how do we treat hamstring tightness, guy? It is only by pushing the knee into extension. We have to move it in the direction of that pain. And that is what we call direct technique. So in direct technique, the therapist move the body in part or the body part in the direction of restrictive barrier. And it is direct technique that we use in all stretching. You want to stretch piriformis muscles, you have to move it in the direction of the pain. You want to stretch a bicep muscles, you know when bicep is tight. If you want to stretch it, you have to extend the elbow. And when you are extending the elbow against a tight biceps, there will be pain, but that's the solution. So direct technique is generally used for stretching, all right? Then we have indirect technique. In indirect technique, the therapist move the body part of the patient away from the direction of the pain. As you see in the lower diagram, it is assumed that the patient is having movement restriction to the right rotation of the neck. And you see what therapist is doing? After applying traction, he rotated the neck opposite to the direction of the barrier, that is to the left, to create a space on the right, so that after delivering the thrust, whatever is blocking the joint on the right will go back to its rightful place. So this is indirect technique. And from what I have said, you know, I've described that something is blocking the joint, and that is impingement. So basically, we use indirect technique to resolve impingement. We use direct technique to stretch a tight structure. Maybe a tight muscles, a tight tendon, a tight ligament, anything that is tight is going to be by direct technique. Whenever there's impingement, it's going to be indirect technique. All right? So let us get that term correct. Now, another term I want us to be familiar with before we go into the detail of other technique is the concept of physiologic barrier and anatomic barrier. All right. You know, where you are seated, if I ask you to rotate your neck to the right, just rotate your neck to the right, you will rotate and stop at a point, isn't it? If I now ask you, try harder, you can do more than that, then you will still go a little bit more. So that means there are two major barriers before you reach the end of the movement. The first stop that you have, all right, that first stop that you have is due to muscle tension. No, the muscles acting in opposition to that movement have reached a state of tension. That's when you stop. Now, the other command that came when I say, oh, can't you move it a little bit further? You push it a little bit more, then another stop comes. The second stop is probably due to tension in the ligaments. And if you try to push it beyond that second barrier, there might be injury. And that is also the phenomenon that will make use in carrying out thrust or mobilization to a patient. We can move their joint to an extent they are comfortable, and then we can move it a little bit further to get the second stop. But if we try to move beyond that second stop, there will be a iatrogenic effect. We are going to introduce injury. So the first stop that is usually due to soft tissue is what is called physiologic barrier. Okay? And the second stop, beyond which you don't go any further, is what is called anatomic barrier. And that one is usually due to ligaments holding the bones in the joint. The first one is due to soft tissue. You can see from my diagram here. Can you see from my diagram here? Somebody can do exercise, active range of motion or passive range of motion, and take it to the green zone, which is the zone of what? Physiologic barrier. But if a therapist now comes and help the patient to do mobilization or manipulation, we push the joint a little bit more than what the patient can do, but we are also limited because we are going to get to anatomic barrier. That is the red zone. And if you try to move the joint beyond the anatomic barrier, there will be complications. I hope we get that. So that's another term I want us to be familiar with. Well, the next term I want to talk about is the pop sound that usually comes with manipulation or manipulative thrust. You know, that cracking sound. I wish we were in a physical class so that we have a very good demonstration. What is this sound? What is responsible for it? And what is the clinical relevance of this sound? I hope there's no problem. I'm hearing a voice. I'm hearing a voice on the ground. I hope you can still hear me, class. Okay, I'll just continue then. So the second point, like I said, I'm going to talk about is the pop sound. What is responsible for this pop sound, and of what clinical relevance is pop sound in mobilization or manipulation? It usually come with manipulation. It doesn't come with mobilization. Well, research evidence have indicated that it is not coming from the bone. You know, ordinarily, your intuition will tell you that it's coming from the grating of the bone. It's something that is very similar to when you snap your fingers. You know, when you push your finger down and you grate your finger and you hear that sound. You probably think they are coming from grating of bones on bone. But listen to this. If it is coming from one bone grating on another bone, then you should be able to repeat it as many times as possible within a minute. But maybe you have not noticed before. You can try it again. Try to snap your finger or grate your finger like that. It will take you another 15 minutes before you'll be able to repeat the same movement. So if that is true, that shows that it's not the bone that is responsible for it. It is a different mechanism that is responsible for that sound, that pop sound. It's the same mechanism responsible for pop sound in manipulation that is also responsible for that snapping sound of the finger. Now, what is actually responsible? You know, when I was trying to describe the manipulation to you, I said the therapist will have to lock the joints, isn't it? When you lock the joint like that, and many of these joints are synovial joints, they have synovial fluid and they have gas dissolved inside that synovial fluid. By the time you lock the joint, you increase the pressure on the fluid. Because you're increasing the pressure on the fluid, you know Boyle's law now that says that pressure and volume are inversely proportional. The volume of the gas inside the fluid will be reduced. Some gas will come out of the synovial fluid in form of cavitation. And by the time you now deliver the high velocity, low amplitude, you will collapse that cavitation. So what is producing that pop sound is the formation of the cavitation and the breaking of it. And research evidence has shown that it takes another 15 minutes for the gas bubble to reform inside the synovial fluid. And that is why if you crack and you get a pop sound, if you try again the second time, you can't get a pop sound from the same joint. It takes another 15 minutes before you'll be able to get it. So basically, that sound is coming from the soft gases inside synovial fluid, which will now form cavitation. And so the formation of the cavitation and the breaking of it as a result of locking the joint and delivering of high velocity, low amplitude is what is responsible for that sound. All right. So what about the sound then? A lot of literature and patient response have linked the presence of that sound to positive benefits in manual therapy. Sometimes when that sound comes, patients will report or therapists will measure increase in the joint range of motion. It makes the patient to even feel relaxed. You know, they feel like something good has been done to their body. Sometimes when that pop sound comes, pain is also relieved. So the presence of that pop sound have been associated with a lot of therapeutic benefits when it comes to manipulation as listed on this slide. And again, patients feel invigorated and they have a sense of relief and well-being after that sound is relieved. But does it mean that when that sound is not produced, your manipulation is not effective? The answer is no, because we still get result, a very good result from manipulation and mobilization without the pop sound. So it doesn't mean that if you don't get it, then the technique is useless. No, it is not like that. And just like I told you, it's going to take approximately 15 minutes once one sound is formed before another one could be formed. Okay, so let's leave the concept of pop sound. The next concept I want us to look at is the concept of kinematics. Even though this is more related to peripheral joints, we still have to talk about it tonight as we are dealing with spinal manipulation or mobilization. Some of the concept also is applicable to the spine. So what is kinematics? Kinematics is a branch of biomechanics that deals with movement. All right. You know, in our ordinary physics, we say that a force can be used to start a movement. Isn't it? If you want to move an object, you must apply a force. So a force is useful to start a movement. A force is useful to stop a movement. A force is useful to change the direction of movement, isn't it? So when you are considering the force and the movement, that is biomechanics. But when you are considering the movement alone without reference to the force, that is kinematics. Do you understand now? So kinematics is the aspect of biomechanics that study the movement without reference to the force. All right? So we're just talking about movement